Afternoon, everybody. Welcome to this CooperSurgical session. It's a great honor for me to have you here in this room. My name is Martine Nijs. I'm the Director of Professional Education at CooperSurgical Fertility Solutions. I'm part of the professional education and clinical support team of our company. So I'd like to welcome you to this CooperSurgical session at ESHHRE 2024. Here in the beautiful Amsterdam, we've got great weather today, but we're sitting inside. We're going to explore science today. Today we are here together to get really up close and personal to Professor Alviggi and Professor Campbell. And we will discuss if there is evidence and what their insights are in personalized treatments. So Professor Alviggi, please, welcome to you. Professor Alviggi is specialized in obstetrics and gynecology and obtained his PhD at the University of Naples. He is a leading expert in reproductive medicine with extensive contributions to research, clinical trials, and international collaboration. He is from the University of Napoli, Federico II. So welcome, and I also welcome Professor Campbell. So please. She is the Chief Scientific Officer of the Care Fertility Group. This is a large group of 19 clinics around the world. Professor Campbell is a renowned expert in clinical embryology and is recognized for her pioneering work in embryo selection technology and her dedication in training and following the development of future embryologists. So before we start, I have to disclose that both speakers receive a fee for this presentation from CooperSurgical, and they represent their own, they're speaking on their own behalf, and they express their own opinions. Now, we have invited two experts to discuss personalized treatments in ART, also known as precision medicine, which is increasingly recognized as a crucial aspect of healthcare, and that can coexist with traditional and standard practices. It involves tailoring our treatments, the medical and the laboratory treatment, to the individual characteristics of each patient, which can lead to more effective and efficient healthcare. So one of the groups of patients, these are the older patients, they often present themselves in our clinics. And is it important? The age at the time of the intake, it might be crucial, may it influence the initial assessment, diagnosis, and treatment planning. But there's also the age of the treatment itself. So when the transfer is being done, or the oocyte retrieval, or the transfer of the cryopreserved embryos. So especially if there's this time gap between the two, between the intake and the transfer, this may affect continuity of all the treatments. So Professor Alviggi, I will bring my first question to you, and that is, should both ages be considered, so the time of when the patient arrives at the clinic and the time of the actual treatment transfer? So should both ages be considered in the female age care continuum? Please.
So Martine, thank you so much for this question. And first of all, good afternoon to all of you. So happy you are here. So age is an incredible issue in our clinical practice nowadays. This is something that we have every day. We have to manage time-sensitive patients. But when we talk about aging, we have to keep in mind that we have two, I can say, parallel phenomena. One is quantitative and the other one is qualitative. So let's start from the qualitative point of view. What you can see on this side of the slide is that throughout aging, we have a progressive decline in the quantity of follicles. This phenomenon is very slow, and there is no particular acceleration, it's constant. And what I would like to point out here is that you can see that, at least in terms of anti-Mullerian hormone, once you reach advanced age, meaning between 38 and 42 years of age, you have an incredible inter-individual variability. So you can have two women 40 years of age, and they can have totally different amounts of follicles and values of anti-Mullerian hormone. Let's move on the other side of the slide. You can see the behavior of qualitative aspect. We measure quality at the moment by the rate of euploidy in our clinical practice. You can see the opposite, that the quality in terms of euploidy rate is quite stable between 28 and 35 years of age. But once you reach 35 years of age, it begins an incredible acceleration of the rate of the decrease in the rate of euploidy. And the behavior is totally the opposite, because if you see the range between 38 and 42, you see that the inter-individual variability is very narrow. So the phenomenon is preserved. So you can have two women 40 years of age, and they have predictable rates of euploidy. This is very important because the balance between quantity and quality can give us the possibility of personalizing counseling. Because you can have a 40 years of age patient with a given expectation in terms of euploidy, and it makes sense to treat these patients if you can balance this deficiency in quality by increasing quantity. But this is only possible in patients with very good ovarian reserve. This is something that I would like to show you. This is a nice experience that we had inside the POSEIDON group. And this is just to stress one concept, that someone says that aging process starts after 38 years of age. It is not totally true, because if you see the window between 35 and 38, you can see that even in this window, there is year after year an incredible acceleration in the decrease of euploidy rate. There is a difference between 35 and 36, between 36 and 37, and there is even 15% the decrease in the euploidy rate between 37 and 38. So probably 38 is too late. And you can see it in a very clear way, even by a clinical point of view, because if we have a look, I proposed this trial that has been published by a Japanese group, because one could ask, yes, this is the rate of euploidy, but what is the clinical result? What do we see in the clinical practice? It's practically the same, because in the upper side, you can see the cumulative live birth rate, which is very important endpoint by clinical point of view. And you can easily see that the same, between 35 and 37 years of age, you have a 10% decrease in cumulative live birth rate. And the same is in terms of spontaneous conception. The same group reported a spontaneous pregnancy during expectant management or timed intercourses. And you can see the same, that between 35 and 37, you have a 10% decrease, year by year, 10% decrease in the probability, in the chance to be pregnant. So the first take-home message from this part, aging is important, and aging becomes relevant after 35, and obviously after 38 is worsened, but we need to pay attention to this window between 35 and 38.
Thank you so much. Very insightful. So, advanced age clearly has an impact on the quality, the quantity, and the number of oocytes for these ladies. So, every year counts for those female patients. So, Professor Campbell, can you show some evidence, if you have the same observation, that there is an impact of age, advanced age, on oocyte, but also on sperm, so in the male patient?
Thank you, Martine. Yes. So in recent years, there's been a significant progress in our understanding of the causes and clinical significance of sperm DNA damage. And many factors contribute to this DNA damage in sperm, including lifestyle, environmental factors, and of course, male age. Although we don't really have a universal definition for advanced paternal age like we do for females. So there's a lovely review, the Gonzalez Systematic Review from 2022, and this describes how older age is associated with increased sperm DNA fragmentation in men. And it's widely reported that sperm DNA damage, both single and double-stranded DNA fragmentation, can, in oocytes of older women, as it can cause issues more in the oocytes of older women than in younger women who may have the ability to repair that damage. So the impact is important for both male and female age. Now there's a lovely hypothesis, a bit of a mouthful, the post-meiotic collusion hypothesis by John Aitken. And this talks about the involvement of both sperm and oocyte in determining the consequences of sperm DNA damage for the embryo. And this could explain why DNA damage can result in increased mutational load in progeny. So we don't have the methods currently available to fully assess the oocyte's ability to deal with this DNA damage, but it's certainly a very important area for our research. And I think we're talking about age and time we'll come on to a little bit later on, but we need to try and find the right balance between investigations, particularly in the male as well as the female, that take time, more testing, more analyses, more assessments, when the clock is ticking, the biological clock is ticking, and it's not just for the woman. And this meta-analysis by Dye and colleagues included 19 eligible publications relating particularly to unexplained recurrent miscarriage, and this included over 2,000 patients. And the results of this study showed that couples with unexplained recurrent miscarriage had significantly increased levels of sperm DNA damage and decreased progressive motility. And this is with and without recurrent miscarriage. This study focused solely on recurrent miscarriage. And the sperm DNA fragmentation assay, we think now could be an important inclusion for assessment in terms of unexplained recurrent miscarriage. So what can we do about it? What should we be thinking about in the clinic and in the laboratory? So if we identify that we have high DNA fragmentation at diagnostic semen analysis, or else if there's a patient indication or expectation that there may be high DNA fragmentation, and there are several things that we can do. So short duration of abstinence is one, and we see this in the literature over the years, and there's some studies that demonstrate this really well. And this meta-analysis by Barbara Gallo from Catania, Italian, the good, showed that producing a consecutive ejaculate very soon after the first could be quite a simple and useful strategy for improving the quality in terms of DNA fragmentation, to have a lower proportion of DNA fragmented sperm in that second ejaculate, which could be used for clinical treatment. So they observed this particularly in the samples that were not normosospermic, but for normal samples, this phenomenon wasn't seen. We can also ensure in the laboratory that we don't leave the sperm in the seminal plasma unnecessarily long. So let's prepare as soon as we can. Let's get the sperm out of the seminal plasma as soon as we can, and there's some nice studies to demonstrate this. And surgical sperm recovery is also sometimes recommended if we know there's high DNA damage. But it may be that there are easier and more patient-friendly alternatives to try first, such as adapting these intervals, abstinence periods, preparation periods, and we'll come on to later a bit more about how we may be able to select the sperm with the lowest proportion of DNA fragmentation.
Yeah, that's super great information. So we really need to focus on the male patient as well and take this advanced paternal age into consideration. Now, Professor Alviggi, you have worked intensively on the POSEIDON criteria. Now, POSEIDON is patient-oriented strategies encompassing individualized oocyte number. That's a mouthful but it's very impressive. So these criteria, they argue that the first step is to move from a poor responder to a poor prognosis concept, while improving identification and stratification of the different subtypes of poor prognosis patients prior to ovarian stimulation. So how will these criteria, how will they help define the marker of success for a personalized treatment, Professor?
So, Martine, thank you for these questions. We are talking about precision medicine. We are talking about matching patients and protocols. So the first thing that we need to do for having this aim is to have a good stratification of patients, good prognosis, low prognosis, and inside the low prognosis to identify specific group with the specific requirements. And the second point, obviously, is the management of low prognosis patients together with the embryologists for having specific strategy that are really personalized. That is what we tried to do in the POSEIDON initiative that started from a group of scientists, friends, and I'm really happy to see here Robert Fisher, Alessandro Conforti, etc., that are some members of the initial POSEIDON group. And basically, as you can see in the slide, the concept is very easy. Yes, the number of eggs is important. So when we talk about poor responders, we mention the number of eggs. But we can easily understand in our clinical practice that the number of eggs has to be related first to age. Because I showed before that there is a specific expectation in terms of a euploidy rate. So in a young patient, for instance, 5 eggs, 7 eggs can be sufficient. In a 43 years of age patient, probably 15 eggs are not sufficient. So the number of eggs is important, but it has to be analyzed with respect to the age of the patient. And the second is if the number of eggs we have is consistent with the expectation, because we need to know the baseline, the antral follicle count, because women can have different sensitivity. You can have a patient with a very good ovarian reserve not responding to stimulation, and patient with a very low ovarian reserve that give the maximum in terms of oocyte. This is POSEIDON, because POSEIDON stratifies patients. You can see that easily that group 1 and 2 are patients that we can call as unexpected, suboptimal, or poor responders, meaning that are patients with a good ovarian reserve that following one stimulation didn't show an ovarian response according to expectation. The second block is group 3 and 4 are patients with expected low ovarian response because of low ovarian reserve. So if we don't distinguish between these two categories, we run the risk of having the patients in the same basket in the clinical trials, in the randomized control trials, in the meta-analysis, and in the clinical practice. And so this is what inside the POSEIDON group has been made in the last years to prove that these groups, different groups of patients, have different prognosis. And if you see this analysis, this is an international network analyzing more than 9,000 cycles, you can see that the 4 POSEIDON groups have different results, different prognosis in terms of cumulative live birth rate. This is very important. Here is showed in a clear way, even including subgroups, because we have to understand at this point that the system is well working in identifying groups that are homogeneous inside. Patients of the same group have specific requirements, but are sufficiently different when you compare among them. So this is very important because if we treat all the low prognosis patients in the same way, and we don't understand that they are different subgroups, we run the risk of not matching patients and protocols properly. So another aim of the POSEIDON, because we know when we talk about endpoints, we say that the best endpoint is the cumulative live birth rate. This is correct. But this is the best endpoint for designing trials. But we don't have in the pocket the cumulative live birth rate. We have to take a decision in the daily practice. And we need something for opening a dialogue, a counseling with the couple. So what is important is an endpoint that we can spend, an intermediate marker of success that we can spend in the clinical practice. That's the reason why POSEIDON has been focused on the idea of establishing, before the treatment, the number of eggs we need for having at least one euploid blastocyst. This is very important because this is what we have in the clinical practice. You see in the line, you can see the decrease in the euploidy rate. So for counteracting 5% euploidy rate that we have when a patient is 42, we need 20 eggs. But we cannot have 20 eggs in the clinical practice. So this is something that the patient has to understand, because if we open the dialogue, we set the aims of the treatment with the couples, we can reach the result together. That's the reason why inside the POSEIDON group, this is something that I have to manage with my right hand. So in the POSEIDON group, we tried to develop, in terms of artificial intelligence and machine learning, an algorithm that has to be improved in time, that is able to calculate the number of eggs that is required for a specific patient for having a given probability to have at least one euploid blastocyst. So this is called the ART calculator. This is the validation test. So let me go in the clinical practice. You can put in the software data from your center, for instance. So your fertilization rate, your blastulation rate for any given age. Or you can use the data that are provided by the software for general population and literature. Once you have done it, you can sit with the couple and you can say, your ovarian reserve is this, but we theoretically need this number of eggs. For giving you an example, so for instance, if we have a patient that is, let me tell you, in this example, 39 years of age, and the sperm, because the sperm source is very important, because the number of eggs changes. If we need a 70% probability for one euploid blastocyst, we need, for instance, 12 oocytes. But if we want 80% probability, we need probably 16 mature oocytes. For almost 100% of probability, we need more than 20 oocytes. This is something obvious for you in your clinical practice. But if you sit down with a couple and you explain this, you can create a therapeutical alliance and to say, we need to have this kind of result. And this is very important for setting procedures, setting expectation, and deciding together which is the best way to go on.
So that's so insightful, very new to me. But I just want to make the right conclusion here. So once we have set the clinical aims, we have identified those, and we have met this therapeutic alliance with the patient, then we consider a clinical strategy. Is that correct? And
yes.
So we can optimize oocyte yield and quantity?
Yes, this is something that we can decide together with the couple, and then we can go inside to the therapeutical approach. So this is for the typical POSEIDON, I can say, protocol, because the first of all is understanding prognosis of the patient, meaning age, meaning clinical history, presence of endometriosis, male factor, and everything. And if the couple is good prognosis, and the patient in particular is good prognosis, obviously the aim is optimizing, maximizing the number of eggs. So we can decide which is the ideal number of embryos if we want to move to one stimulation, one family approach, or we want to move to mild stimulation. What is important is understanding that the patient is good prognosis. If the couple and the patient is low prognosis, the first thing to understand is the ovarian reserve and the age. Obviously, if the ovarian reserve is very low, we can say that the patient can be categorized as a group 3 or group 4 POSEIDON according to age. Age is important, and that's the reason why we identified as a cutoff 35 years of age for the reasons I explained, I shared with you at the beginning of this meeting. If the ovarian reserve is apparently normal, if the patient is at the first ovarian stimulation, we can consider the patient good prognosis. But if in a previous cycle she had suboptimal response, meaning, or even poor response, meaning a lower number of oocytes than expected, we can categorize the patient as a group 1 or group 2 POSEIDON. So once we have categorized, we can say, listen, you are this category, you stay in this category. Obviously, your situation is individual, but in this category, the expectation in terms of live birth rate is this. But we need to be more precise, and we need to understand how many eggs you need for having at least one euploid blastocyst, or for optimizing your prognosis. So once you have calculated the ideal number, you can decide strategies. And this is the point where I want to explain the difference between POSEIDON groups 1 and 2 and group 3 and 4. This is an example of a patient that because I think that in the clinical practice is easier to understand. We have a patient that at the end of the stimulation had, I can say, 3 eggs. So we can say is a classical poor responders. But this patient, if you can see, at the beginning of the cycle had 15 antral follicles. So 3 eggs at the end, 4 follicles reaching maturity with a baseline of 15. So the sensitivity of this ovary was lower. So probably something went wrong during stimulation, or probably the sensitivity of this ovary is not, I can say, perfectly consistent with the expectation. Why? Probably because some polymorphisms of the FSH receptor can be there. There is a huge body of evidence demonstrating that some allelic variants of FSH receptor can impact the ovarian response to exogenous FSH. Even in the LH system, we can have polymorphism of the LH or LH receptors that have been associated with resistance in the ovary. So you have a good ovarian reserve and less oocytes, less follicles growing than expected. So in this case, the patient is a poor responder, 3 eggs. But in a second stimulation cycle, in this patient, it makes sense to change something. It makes sense to increase the dose. It makes sense to move to another gonotrophin, to move from agonist to antagonist, to add LH at the stimulation, to add recombinant LH is even proven that works. So if the sensitivity of the ovary was low, we can modify the prognosis in the second stimulation cycle by modifying the, I can say, the ovarian stimulation. But let's move to an example of a patient categorized as a group 3 or 4. In this case, you have 3 eggs, the same of the previous patients. But in this patient, it was expected because the ovarian reserve was very low. In this case, it makes no sense to increase the dose. It makes no sense to change gonotrophins because this patient exploited her potential, 4 antral follicles, 3, 4 oocytes. So in my opinion, is even a good responder despite 3 eggs. So totally different mindset. And so what we need, if we have the ART calculator and the patient knows that she needs at least 10 eggs, the only way to reach this result, in my opinion, is proposing an accumulation program. That can be duo-stim, 3-stim. You can, if you have set the target with the patient and the patient understands that she cannot reach this target because of her ovarian reserve, the answer to this problem is not increasing gonotrophin dose. We cannot create new follicles, is providing an accumulation program. And we must find an agreement with the embryologist. We have to dialogue because we have to understand how many eggs we need, the sperm source. We have to optimize the results. We have to plan if accumulating for PGT-A analysis, for single embryo transfer. We need to design precision medicine for that given couple.
Thank you so much for explaining this excellent clinical tool. Now, let's move to the lab, Prof. Campbell. So once the quality and the quantity has been maximized by the clinician, do we have lab tools that can support the development of the embryo, the implantation, or even help sustain the pregnancy?
Thanks, Martine. I thought you'd never ask. Yes, we have plenty. We have lots of lab tools. So, yeah, let's talk about the lab. Oh, yes, so we have tools in all areas of the lab, and we don't have time to talk about them all today. But you can see here lists of things that the lab needs to consider in terms of the gametes, the fertilization, and right through to cryopreservation. And it's important that we do have these tools and we have access to them and we're trained in them and that we use them for personalizing the treatments. So before we go into some of the details of specific tools I'll use as examples, it's important to state just how many lab factors there are and how they can impact outcomes. So this lovely paper by Don Rigo is often quoted that 175 lab factors influencing outcome and quality. And we know that everything is important in the laboratory, every single detail, and this Cairo consensus guideline on IVF culture conditions really describes this well, so I'd urge you to have a look at that if you're not aware of it. But a key role of our embryologists is to protect the gametes and select in the laboratory. We receive them from the patients with the help of our wonderful clinicians, but we can't change them, we can't make them any better, so everything we're doing has the potential to stress them and cause them harm and compromise outcomes. So our key role really is to protect and also to select. And in most geographies and jurisdictions, all oocytes are available and suitable, and those suitable will be used for treatment. But sperm, we have millions often, and that's one area that we need to think about a bit more closely. So going back to sperm, so recent years we've seen the introduction of microfluidic sperm preparation devices with some really interesting results, and particularly in relation to DNA fragmentation of sperm. So Quinn and colleagues in 2018, with 70 semen samples, performed a paired analysis, and they reported significantly lower DNA fragmentation index after the Zymo preparation, the microfluidic device, that's compared with density gradient and swim up, and the unprepared sample as well. And Eldorado et al. 2023 performed a systematic review and meta-analysis with over 1,600 embryo transfers. And they saw marginal positive outcomes compared to standard sperm techniques when they used microfluidic devices. But it's important to state with this analysis, there are 3 different microfluidic devices involved, and the control groups were fairly heterogeneous. We had some surgical sperm recoveries, density gradients, swim-ups. So earlier this year, we've got a Nijs study by Scude Logares and colleagues, and they looked at donor oocytes, and they showed that the microfluidic sperm selection enhanced the success in ART cycles with ICSI, and especially in couples with advanced paternal age. And we mentioned this earlier, but in this study, they set advanced paternal age at 45 years. So they proposed advanced paternal age as a new indicator for the application of these microfluidic sperm selection devices in order to get this DNA fragmentation reduction. And I think there are many benefits, not only for these patients potentially with high levels of DNA sperm fragmentation, but in the laboratory they're great to use. They're very popular with the embryologists because they improve workflow. Often, certainly with ICSI, there's no need for centrifugation. It's a single receptacle, so we don't have the issues of witnessing between different steps. So, and they save time, so quite popular in the laboratory, so I think we should watch this space. And certainly at Care Fertility, we've been looking at the Zymo device, and I've got my colleagues here from IVF Life, experts, and they did a wonderful study. They took 25 semen samples, and they looked at the different variables. They looked at, she's here, Janos is here, they looked at apoptosis, DNA fragmentation, motility, and they found significantly lower DNA fragmentation in the sperm prepared with the Zymo device compared with the other methods. And back in the UK at Care Fertility, we did a retrospective analysis of treatments where patients had undergone 2 ICSI cycles in 17 months. One time we'd used density gradient, and another time Zymo, and we found high significance in terms of embryo utilization and positive pregnancy rate and clinical pregnancy rate in the Zymo prepared sample treatments compared with the standard methods, density gradient. So these are unpublished studies, but I think it's nice to share a personal experience. So and this one is this is another tool that we've got to look at the sperm, and we talked about the importance of selecting the best sperm, and it's to increase the patient's chances. So it's a well-known published study in the Lancet 2019. It was the HAB Select trial, and this was over 2,700 unselected couples from 16 IVF centres around the UK. And here they report a significant reduction in miscarriage rate when they used a PIXI dish for sperm selection. So PIXI being a hyaluronan binding dish. So the sperm are binding to the plaques of desiccated or rehydrated hyaluronan to show their maturity and their integrity. So it's a great way to select the best sperm. And this publication is really important, I think, for us. It's a very large study, and there's further analyses gone on in this area. So miscarriage reduction was a significantly important secondary outcome of the HAB Select trial. So 1,247 samples that were selected for a mechanistic analysis, and this was deliberately enriched for the miscarriage outcomes. And then a predictive model, fire alarms going off, a predictive model for female age was built, and it reported that older women randomized to the PIXI dish had the same live birth rates and the same lower miscarriage rates as the younger patients. So this being most likely due to the avoidance of the sperm with the damaged DNA. So the modeled live birth and miscarriage data strongly suggest that performing ICSI with this hyaluronan binding element in a PIXI dish helps to overcome the negative effects of advanced maternal age. So suggesting that PIXI is a good tool to select sperm for women over 35. So it could be that this is one of the quite simple tools that can be effective for females over 35, or also for couples with advanced paternal age, for the older males. So let's move on to the embryo. We're not going to be nervous about the fire alarm? No. So our group at Fertility recently published a systematic review and meta-analysis on morphological and morphokinetic associations with aneuploidy. And we found from this big analysis that most studies demonstrated a moderate risk of bias. And we found 7 morphokinetic variables were significantly delayed in aneuploid embryos. Also, one of the conclusions being that blastocysts displaying increased frequency of contractions were associated with aneuploidy, but there were just 2 studies that reported that. And also multinucleation that persisted to the 4-cell stage, there's an association with aneuploidy was found. And there was also a strong trend between increasing fragmentation and aneuploidy, but the evidence was recorded as low certainty. And this year, we published a study which compared morphological selection with morphokinetic models. So we looked at both artificial intelligence models and statistical models that we'd developed for embryo selection. And we found that our AI and statistical models were more effective than embryologists, unfortunately for us, more effective than our morphological assessment. And this, in turn, was more accurate than random selection. So arbitrary and random embryo selection would rank the euploid embryo first 37% of the time, the embryologist with the morphological assessment 39% of the time, but with the AI and the statistical models, 46 and 47% of the time, respectively, would they rank the euploid embryo first. So we've got some exciting tools available, and more under development. So another lab tool is a new culture medium, which contains a cytokine GM-CSF. I think Cooper have done a nice job of preparing us for this. We've seen it. I've been bombarded with messages on Facebook and LinkedIn, but I think it's an important new product that I'd like to talk about briefly. So cytokines are essential for embryogenesis, or this cytokine, GM-CSF. They affect embryo survival through precise receptor-mediated communication. And GM-CSF is an embryokine, so it protects from apoptosis. It's associated with glucose uptake, normal glucose uptake. So I just think of this quite simplistically as multi-talented. It has so many important roles. And it's there physiologically during embryo implantation and the early fetal development. So there's a large 14-center double-blinded placebo-controlled RCT, over 1,300 patients by Zeeb et al. This was probably about 10 years ago now. And it showed that GM-CSF, this cytokine, can promote blastocyst viability and increase the chance of implantation, and particularly for women with recurrent miscarriage. So this chart here shows a subgroup analysis for the previous miscarriage, and we see significantly better outcomes when we use this specialized medium. So I think also, just briefly, we have a few comments about when we're talking internally, and we were talking before about a cytokine in a culture medium, but this is a decade-old study, and there have been no reported incidents, adverse events, stillbirths, perinatal deaths, or abnormalities. So we've got confidence in the safety of this product. So this one is really particularly interesting. So again, we're using this new culture medium supplemented with GM-CSF. So it's a single-step medium now. We've moved on from 10 years ago when it was just an early stage culture medium. Now it's a universal right through to the blastocyst stage. And this is a longitudinal retrospective propensity score matched cohort study from Japan. And what they did, they warmed 566 vitrified blastocysts, and they cultured them for 3 to 5 hours prior to transfer in this stage 1-step GM-CSF. And they reported significantly increased clinical pregnancy, ongoing pregnancy, and live birth rates compared to culture medium when they used their standard single-step medium for post-warming culture. So this is really interesting. So we obviously need more studies, but I think it's something to watch, and I'm quite optimistic about it personally.
Thank you so much for enlightening us on all these tools. Some need more evidence, but there's a lot of great stuff in the pipeline for personalized treatments. Now, you yourself, Professor Campbell, as well as Prof. Alviggi, you mentioned that every year counts. So can I now bring PGT-A into this discussion? Is PGT-A the way to reduce the time to pregnancy for advanced age or other patients, or repeated failure of implantation? So first, perhaps, Professor Campbell, can you comment on this?
Yeah, we can't go anywhere without talking about PGT-A. It remains a hot topic. Well, there are very many retrospective PGT studies showing different benefits of PGT, but the randomized controlled trials we know are limited. We had the STAR trial, we've got the SART data, and we've got other multi-center analyses, and they do point to efficacy for women over 35. And we had the Teague's non-selection study, 2020, which demonstrated sustained implantation and live birth for transfer, or no sustained implantation and no live births for the transferred aneuploid embryos. And the Yan study, 2021, reported that among young women with 3 or more good quality blastocysts, they had the conventional IVF treatment resulted in a cumulative live birth rate that was non-inferior to the rate of PGT. So it seems if they're young patients with a good number of embryos, we don't see those benefits necessarily. But what they did find was lower early pregnancy loss in the PGT group. So we may not see any benefit in cumulative pregnancy rates for those younger patients. We do see a better, much lower miscarriage rate, which I think is very important, and this is what we can go on to talk about a bit more. So recently in the UK, the regulator, which is the Human Fertilisation and Embryology Authority, they have a rating scheme for what we call add-ons, so anything that's additional to your basic treatment cycle. So PGT is considered an add-on. And this rating review, it follows a independent literature review of randomized controlled trials and high-quality cohort studies if there are no randomized controlled trials. And it uses established methodology. I've been quite closely involved with it, and it's very, very rigorous. And for PGT, they've given it now a green rating for PGT, for miscarriage particularly. So they say that on balance, the findings from high-quality evidence show that this add-on is effective at reducing the chance of miscarriage for most fertility patients. So this is a really important point, I think. And this has come up very recently, July 2024. I'm not sure if people have seen this, but Carlo and I were really intrigued by this quite short commentary by Amber Cooper and Manuel Viotti. And they stress that their view is that PGT is a screening test and that time to a healthy baby is the key purpose of PGT-A, which we think is a great sentiment. And PGT is a ranking tool to help us select the embryo with the best chance of being a healthy baby, and also to select the embryos, or identify the embryos least likely to end in a failed outcome or a miscarriage. And they argue that it's time to do a few things. Stop referring to PGT outcome reports as normal or abnormal. Stop referring to embryos that way. We need to improve patient counselling and also our understanding as professionals, our understanding of the platforms and the tests available to us. And they also say that we should be obtaining permission to discard aneuploid embryos and stop denying mosaic transfers. So it's quite a provocative commentary, but it was really fascinating to read, and I think largely we're in agreement that this is a good way to be thinking. Now this one is a nice tool to talk about the time and cost effectiveness of PGT-A. So it's a decision analytic model that's been fairly recently published, and it was a multi-center, 74 centers, 9,000 treatment cycles, looking at women under 43. So the primary outcome of this analysis was the cumulative IVF-related costs to achieve a live birth or to exhaust all of the embryos from one single egg recovery. And the secondary outcome was time from the retrieval to transfer, resulting in a live birth or completing all the transfers or clinical pregnancy loss, failed transfers. So what they found were four things, really: that PGT-A reduced the time in treatment by up to 4 months, that in terms of cost, which is really important when we're thinking about PGT-A, it's not cheap, but it favoured PGT-A providing there's more than one embryo. It was more cost effective to do PGT-A. Cumulative live birth rates were equivalent whether you do PGT-A or not, which makes sense. And PGT-A reduced the risk of failed embryo transfer and miscarriage. So I don't know, Carlo, if you wanted to say anything about that.
No, you told everything, and this is quite. But I take the opportunity for a comment, because sometimes we need evidence-based medicine, but sometimes we cannot be totally dependent of this, because if we have something that is clear in our clinical practice, we have to think with our mind and try to understand and find a balance between evidence. So sometimes we make some mistake in clinical research, because we take the wrong endpoints, the wrong methodology, the wrong study population. We have a given result, and cut and paste, we apply these results in general population. There are so many examples. And one is related, in my opinion, to PGT-A, because vast majority of trials, the historical trials, have been performed in patients below 37 years of age, and sometimes having a cumulative live birth rate as endpoint. But we cannot expect an increase in cumulative live birth rate, and it is not useful to apply PGT-A in young patients. And so we run the risk that cut and paste, we apply the results from a randomized control trial to the general population. So what is in our clinical practice? What we can see that we avoid an incredible amount of unuseful transfers. So if we merge together all the information that is emerging now, is that we have 40% patients that are low prognosis and time sensitive. If I have a patient who is 39, 40, the rate of euploidy is 20%. The ovarian reserve is decreasing. So take the example that this patient has adenomyosis or very important endometriosis or myomas. She has to have surgery. If you have a 3 blastocysts and you transfer 3 blastocysts, 4 blastocysts every second month, if the patient is not pregnant, this patient has lost 1 year. And this is very important because in 1 year the rate of euploidy will be lower, the reserve will be lower. If I can have a criteria for prioritization of the embryo and I can avoid unuseful transfer, I can manage surgery in this patient before transfer. I can go straight to the point, and if I have no euploid blastocyst, I can go to the following, to the next stimulation. So in a clinical practice, we can use tools. So evidence base is important, but I cannot understand if we stop something that can be useful because we don't have the ideal randomized control trials having time to pregnancies as endpoint. This is my personal view.
This is a great add-on, And on that point of prioritization of embryos or ranking of embryos for transfer, I think it's really, really important that there is communication between the clinic, the lab, the nurses, the genetic counselor, etc. So what do we know about that? How important is that, Prof. Campbell? And can you give some examples on timings and communication with the clinician, with the patient, etc.?
Yes, very important, absolutely. And we've spent a lot of time talking about this point together. So delivery of fertility treatment involves teamwork, of course it does, within a discipline, within the laboratory, but also across the clinic, with the clinical team, the nursing team, administrative team. All of the teams need to work together with the patient in the middle of everything. So this review that I was involved in here primarily focused on teamwork within the IVF laboratory, but it discusses all of the elements around it and how important it is to work together. And we're in full agreement that the trust and respect that you can build between colleagues is really crucial to get these best outcomes for patients and patient care. So one way that our teams can work together in the interest of clinical outcome is to understand the importance of timing. You know, so many times there's a little bit of conflict. Well, what time can you do this egg collection, or can you come in on a Sunday, and all of that stuff. But it's really important that we're mindful of what we're doing with these timings can impact patient treatments. And there are many studies that look at the timing of ESHHRE outcomes, but they're quite conflicting. But this one is an interesting one by Pujol et al., and it indicates that in vitro aging of mature oocytes significantly affects the chances of pregnancy. So once the oocytes are in the laboratory, we need to start to think about timing. It's very important. And they concluded that limiting the incubation time of the mature oocytes in the embryology laboratory can really improve reproductive outcomes for patients using their own eggs and having a fresh embryo transfer. And we've done some work in this regard at Care Fertility. Again, this is an unpublished study, but I wanted to share it with you because it's large. We looked at 51,000 ICSID oocytes, and we found that women over 35, we could compromise their treatments if we allow this in vitro aging to take place. So we now ensure that for women over 35, we perform our ICSI within 4 hours of oocyte recovery. So this is where we might need some cooperation with the medical team and the nursing team who are scheduling the treatments. Because if we were to collect those oocytes, let's say at 8 o'clock in the morning, then we would want to be inseminating them by midday. But this means that if we don't have time lapse, then 6 o'clock the following morning, maybe 5 a.m., we need to be back to see the pronuclei. So we need this collaboration and cooperation to make sure that the workflow is good and, most importantly, that the patients get the best possible outcomes.
And I really like to see that this is the first time I see that both clinician and embryologists focus on specific personalization above 35 years of age. Because if we see the flow as a whole, we see that we have to categorize according to age, and we can personalize not only patient stratification, matching patients and protocols, but we can dialogue with the embryologists and say, listen, this patient is 35, 37, what can you do for improving this low prognosis situation? This is personalization.
Thank you so much. You just made my work so much easier by giving the summary of your presentation and discussion. So thank you so much, Professor Campbell and Professor Alviggi. You can get up close and personal with them. They will be here around during the 2 other days of the ESHHRE. Thank you very, very much for coming to this CooperSurgical session. Thank you.